Hello, wonderful staff of the Northwest Kidney Center, particularly at the flagship unit in Kent, the best dialysis unit in the Western Hemisphere. Today we're going to talk about one of the most common important symptoms experienced by dialysis patients, shortness of breath, also known as dyspnea. Dyspnea is one of the most common side effects experienced by dialysis patients, and it's the most common major symptom among dialysis patients that improves with the dialysis treatment. It's something we see daily when we work in a dialysis unit, and therefore it is important to be familiar with its causes and management. There are three objectives to today's talk. First, I want to appreciate the significance of shortness of breath among dialysis patients, a very common, very important problem. Two, we'll review the causes of shortness of breath in this population. And three, we'll discuss an approach to management of shortness of breath in a dialysis patient. There are dozens of different causes of shortness of breath. We'll just talk about a handful of ones that we most commonly see in the dialysis population. They include volume overload. That's the number one cause of shortness of breath in the dialysis population. There are cardiac problems like heart failure. Patients can have abnormal cardiac rhythms or arrhythmias or valvular heart disease. Anemia can cause shortness of breath. Pneumonia, something called metabolic acidosis. Cardiac tamponade, which I'll explain later. Dialyzer reaction or incompatibility. An air embolism, pulmonary embolism, underlying lung disease such as COPD, panic attacks can do it, among many other potential causes. Shortness of breath, as I mentioned earlier, is also known as dyspnea. It's an uncomfortable feeling of not being able to breathe well enough. Dysk is the Greek word for difficult, and pnea refers to breathing. So basically, it's difficulty breathing with usual activity. There are lots of symptoms. Of course, difficulty catching your breath, feeling a need to breathe more quickly or deeply, not feeling able to take a full deep breath, chest tightness. Patients with dyspnea often breathe faster than usual. We call that tachypnea. And they often use accessory muscles of respiration, like in the abdomen, the neck, the shoulders, and when they are having difficulty breathing. The prevalence of shortness of breath among the dialysis population it varies depending on the study. In one study, it was about 20 to 60%. In another study, one survey suggested that up to 100% of dialysis patients experience shortness of breath. Now, the patients may not look like they're having difficulty breathing, but if you were to ask many of them before their treatment if they feel a little bit winded, say when they walked in from the parking lot, I think many of them would say yes. All right, let's switch gears and discuss the causes of shortness of breath, and I'll introduce different causes in the form of cases. First case is a 49-year-old hemodialysis patient who missed his last two dialysis treatments and presents 8 kilograms above his dry weight. He is short of breath and having difficulty breathing. What is the cause of his dyspnea? A. Pneumonia, B. Volume overload, C. Asthma, or D. COVID-19 infection. And you're right, it is volume overload. So, fluid overload is a common important complication encountered in the care of patients with end-stage renal disease who are on dialysis. Fluid overload not only causes unpleasant symptoms such as shortness of breath and swelling and bloating, but it also leads to an increased incidence of hospitalization and mortality. So, essentially given the association of fluid overload with adverse outcomes in dialysis patients, it's paramount that we identify effective and reliable methods to determine the fluid status in dialysis patients. And to that, we turn to uh, both symptoms or the history as well as a physical examination. A lot of dialysis patients who are volume overload will complain of shortness of breath that awakens them at night. We call this paroxysmal nocturnal dyspnea. Paroxysmal means fit or attack, nocturnal at night. Dyspnea, of course, is shortness of breath. So basically, this is a sensation of shortness of breath that awakens the patient often 1 to 2 hours after sleep and is usually relieved when the patient sits upright. Patients may also complain of something called orthopnea. Ortho is a Greek word for straight, and again, pnea means to breathe. So literally, shortness of breath that occurs when you are straight or lying down, usually flat in bed. In general, patients with heart failure or volume overload breathe more comfortably when they are sitting at an angle or sitting upright. When we sit up, basically gravity takes fluid out of our chest and distributes it into the lower half of our body. And when we lie down, fluid can then migrate from the legs back into the chest and go into the lungs, which causes shortness of breath. Patients with fluid overload oftentimes also have what's called dyspnea on exertion. So again, this is difficult, pnea is breathing, so it's difficulty on breathing with walking or other forms of exertion. Most patients with fluid overload report dyspnea on exertion. In a patient with fluid overload, if you listen to their lungs, you might hear crackles or rowels. These are Velcro-like and tend to occur mainly during inspiration, and they are thought due to the opening of previous closed airways because of the presence of fluid. You might hear a decrease in breath sounds. This is common if a patient has fluid that is accumulated in the pleural space around the base of the lung. We call that a pleural effusion. Many dialysis patients also have what's called wheezing. And wheezing is often heard in asthma, but a lot of patients with fluid overload also have wheezing, and we refer to that as so-called cardiac asthma. So it's important to recognize that not all wheezing represents asthma or COPD. Examination of the heart can also yield insight into the presence of volume overload. So for example, you may hear something called a third heart sound or a so-called gallop. Essentially, this is an extra beat that occurs just after the second heart sound when the mitral valve opens. This allows for passive filling of the left ventricle, and the S3 sound is produced by the large amount of blood striking a very compliant left ventricle. So if you hear three heart sounds, think heart failure. Yes, technically speaking, there's a fourth heart sound, but it's a little bit harder to hear. So keep things simple. Essentially, if you hear a third heart sound in a shorter breath patient, it is fluid overload or heart failure until proven otherwise. You may also hear a heart murmur. Heart murmurs basically represent a disturbance to the blood flow, most often secondary to a problem with one of the heart valves. Heart valves are essentially doors, through which the blood travels from one chamber to the next, and sometimes the valves can become, sclerotic or scarred and shrink inside, and we call this stenosis. And it's very common to be able to hear the turbulent blood flow as it passes through the heart valve. Finally, tachycardia, just having a fast heart rate is often evidence of fluid overload or heart failure. Essentially, faster heart rate is one of the ways that the heart can compensate for its reduced cardiac output in the setting of volume overload or heart failure. Cardiac output is equal to something called the stroke volume, or the volume of blood that is pumped out of the left ventricle with each contraction, times heart rate. So if you want to increase how much the heart is producing, you increase your heart rate. So tachycardia is another sign of fluid overload. Another useful physical exam finding of fluid overload is distension of the jugular vein, or the vein that's in the neck. And if you want to be a superstar dialysis technician or nurse, you can examine the neck and see whether or not it is distended. Furthermore, you can also measure the height of the column of blood above the right atrium, which is a little ways down in the chest here, and that can be used to estimate the pressure inside of the vein, the central venous pressure. Basically, we measure the vertical height in centimeters, and a normal central venous pressure, CVP, is less than 9 centimeters of water. Okay, let's move on to the second case. 70-year-old hemodialysis patient with known heart disease who's recently hospitalized for a heart attack. She presents to dialysis with shortness of breath over the past day. She's very tired because she woke up several times last night with difficulty breathing. She slept in a recliner because she could breathe better when propped up. Why is she short of breath? What's the cause of her dyspnea? A, congestive heart failure, B, pneumonia, C, seasonal allergies, or D, malingering or making it up? And the answer is congestive heart failure. So this is similar to the previous case, but is not in this case due to missing 2 runs and presenting 8 kilos above the dry weight, but due to intolerance of volume overload because of reduced cardiac function or congestive heart failure. So congestive heart failure is basically a syndrome, a group of signs and symptoms caused by an impairment of the heart's pumping function. Um, this is another common cause of shortness of breath among dialysis patients. Symptoms are similar to the first case, basically shortness of breath, dyspnea on exertion, paroxysmal nocturnal dyspnea, orthopnea. The signs are also similar. Lower extremity swelling, crackles on lung exam, sometimes an S3 gallop, sometimes wheezing, decreased breath sounds in the lungs, crackles, etc. The treatment is fluid removal on dialysis. Of course, you want to send them to the hospital if they are hemodynamically unstable, say they have really low blood pressure, or if you remove fluid during the dialysis treatment, but the shortness of breath persists by the end of the treatment, particularly if they have hypoxia. Okay, next case. 80-year-old hemodialysis patient presents to dialysis with shortness of breath. He says he does not feel well. On physical examination, his heart rate is irregular and tachycardic with a rate in the 150s. Why is he short of breath? Is it A, atrial fibrillation, B, pneumonia, C, double pneumonia, or D, triple pneumonia? And the answer is atrial fibrillation. So what is atrial fibrillation? Atrial fibrillation is an abnormal heart rhythm or an arrhythmia characterized by rapid and irregular beating of the top part of the heart or the atria of the heart. Essentially, if the heart pumps really fast, then the ventricles, the bottom part of the heart, don't have time to fill with blood. And so this compromises the efficiency with which the ventricles pump blood into the arterial circulation. Blood then backs up behind the heart into the lungs, abdomen, and legs, and causes venous congestion. If you get fluid in the lungs, it causes the crackles, the decreased breath sounds, the wheezing, shortness of breath. Fluid in the abdomen can cause swelling, and fluid in the legs can cause lower extremity edema. The next case is an 89-year-old dialysis patient who presents to dialysis unit with shortness of breath. This has been an intermittent problem over the past 6 months. He weighs only 1 kilogram above his estimated dry weight of 60 kilograms at the start of dialysis. He is afebrile. On physical examination, you hear a really loud heart murmur. Why do you suspect he has dyspnea? Is it A, walking pneumonia, B, valvular heart disease, C, cocaine use, or D, fluid overload? And survey says valvular heart disease. Excellent. So valvular heart disease occurs when your heart valves do not work correctly. The valve becomes really stiff, so it doesn't open normally. We call that stenosis. Or it can be really floppy and doesn't close normally. That can result in something called regurgitation. So stenosis is what we commonly see. Basically, the tissues that form the valve leases become really stiff, and this narrows the valve opening. So it reduces the amount of blood that can flow through it. And if it's severe, the heart function becomes reduced, and the rest of the body may not receive adequate blood flow and oxygen. Regurgitation, in contrast, occurs when the leaflets do not close completely, and this lets blood leak backward across the valve. This is also known as regurgitant flow. How do we diagnose these problems? We diagnose it with an ultrasound of the heart or an echocardiogram, and this is a mechanical problem which requires a surgical fix. Case number 5, 20-year-old hemodialysis patient presents to dialysis with shortness of breath of several weeks duration. She presents only 0.5 kilograms above her estimated dry weight of 80 kilograms at the start of dialysis. She's afebrile. She looks really pale and reports really heavy recent menstrual bleeding. So why do you suspect she's short of breath? Is it A, pneumonia, B, valvular heart disease, C, anemia, or D, heroin use? And the answer is anemia. Anemia is a reduction in hemoglobin or a reduction in the number of circulating red blood cells. An extremely common problem among dialysis patients is responsible for many of the symptoms that we see with kidney disease, including fatigue and reduced exercise tolerance and shortness of breath. It's also associated with heart problems and an increased risk of hospitalization and hospital length of stay. So there are lots of reasons to treat this problem. Anemia in a dialysis patient is generally defined as a hemoglobin less than 10. The target hemoglobin for our patients is between 10 and 11. There are lots of reasons why dialysis patients are often anemic. There's blood loss, can either be from their fistula or if there's clotting in their circuit. GI bleeding is really common in dialysis patients. Menstrual bleeding, as in this case, can contribute. A lot of dialysis patients also develop nutritional deficiency, either iron or other vitamin deficiencies such as B12 or folic acid. If dialysis patients are sick for whatever reason, say they've been hospitalized with pneumonia, then this can compromise the efficiency with which red blood cells are made. We call that inflammatory block. And finally, the kidneys normally make a hormone called erythropoietin. This stimulates red blood cell production in the bone marrow, and in most dialysis patients, the underproduction of erythropoietin is the main reason for anemia, and it is why we give our patients recombinant erythropoietin in the form of Mircera. So of course we treat our patients, as I just mentioned, with Mircera as well as intravenous iron with the goal of raising their hemoglobin to 10, and this reduces the likelihood of having symptoms related to their anemia. In this case, the patient had a really low hemoglobin of 4.6 and needed to go to the hospital for transfusion. Next case, 75-year-old woman presents to our dialysis unit with shortness of breath. She has a fever as well as frequent cough. She weighs only 0.2 kilograms above her dry weight. She has no edema on exam. There's no heart murmur. Why is she short of breath? Is it A, pneumonia, B, valvular heart disease, C, anemia, or D, congestive heart failure? And you guessed it, she has a fever, she's coughing. This woman has pneumonia. Pneumonia is 5 times more common in dialysis patients than in the general population. In one retrospective study, the probability of being hospitalized for pneumonia was 9% in patients who had been on dialysis for 1 year and 36% for patients who had been on dialysis for 5 years. Symptoms are kind of what you'd expect: cough, fever, chills, pain when they take in a deep breath, shortness of breath. The diagnosis can be confirmed with a chest x-ray. Of course, these infections can be either bacterial or viral, including COVID-19. Next case, 36-year-old dialysis patient who has skipped dialysis for 2 weeks presents with shortness of breath. She's afebrile without a cough. She still makes lots of urine. She actually comes in at her dry weight of 50 kilograms. She's got no edema on exam. Why is she short of breath? Is it A, pneumonia, B, valvular heart disease, C, metabolic acidosis, or D, congestive heart failure? And the correct answer is metabolic acidosis. Excellent. So metabolic acidosis basically refers to acidic blood. It's defined as an arterial pH of less than 7.35 and plasma bicarbonate of less than 22. So the kidneys normally make bicarbonate, which is baking soda, and this helps neutralize the acidity of blood. But if you don't have kidneys, you can't neutralize acid, and so you rely on your lungs to exhale acid in the form of carbon dioxide. So people with kidney failure often breathe more rapidly because their bodies are trying to get rid of acid in the form of carbon dioxide. In this case, a dialysis patient who skips dialysis for 2 weeks can therefore still be short of breath, even in the absence of fluid retention. Next case, 50-year-old dialysis patient with a history of intravenous drug abuse, as well as poor treatment compliance, multiple misruns of dialysis, presents with shortness of breath. He's afebrile, his blood pressure is low at 90/50. On an exam, neck veins are distended and heart sounds are distant and muffled. Why is he short of breath? Is it A, heroin use, B, pneumonia, C, cardiac tamponade, or D, congestive heart failure? And the answer in this case is cardiac tamponade. Fantastic. Cardiac tamponade is pressure on the heart that occurs when blood or fluid builds up in the space between the heart muscle and the outer covering sac or the pericardium of the heart. If fluid accumulates around the heart is unable to expand properly and fill with blood. The heart, therefore, can't pump enough blood through the arterial system, which leads to low blood pressure. Additionally, blood backs up behind the heart in the usual places, so lungs, abdomen, and legs. The two most common causes of a pericardial effusion in a dialysis patient are insufficient dialysis, so poor clearance, and volume overload. And oftentimes, both of these are present in patients who frequently miss treatment. Treatment in this case is more regular dialysis to correct her uremia. Next case, 7-year-old dialysis patient is fine at dialysis onset, but within minutes develops shortness of breath and back pain. She is a febrile, blood pressure is 160/90. There's no murmur or edema on exam. Why is she short of breath? Is it A, pneumonia, B, cardiac tamponade, C, dialyzer reaction, or D, the use of a girdle? Excellent. The correct answer is dialyzer reaction. So a dialyzer reaction refers to all the abnormal sequelae resulting from the interaction between blood constituents and the hemodialysis membrane, or the dialyzer. Dialyzer reactions are infrequent with current dialyzers, although they still happen. I just had a patient a couple months ago who had a dialyzer reaction. It's imperative to recognize potential dialyzer reactions because they can get worse upon re-exposure. So if they have a dialyzer reaction, then go through the same treatment in the future, the reaction can be even worse. There are two reactions that patients can have. One is anaphylaxis, which is a severe whole body allergic reaction to a chemical that has become an allergen. And the second is an anaphylactoid reaction. It's similar, it mimics anaphylaxis, but it's not mediated by immunoglobulin E immune response. Most often, dialyzer reactions occur in patients because of exposure to something called ethylene oxide, which is commonly used to sterilize dialyzers, but can also occur just from exposure to the membranes themselves. Reactions generally include flushing, itchy skin, wheezing, swelling of the throat, difficulty breathing, headache, back pain, chest pain. Depending on the severity, treatment may include epinephrine or steroids or oxygen. Sometimes patients even need intubation and, of course, changing the dialyzer. Next case, 50-year-old dialysis patient is fine at dialysis onset but develops shortness of breath and passes out shortly after starting the treatment. Is a febrile, normotensive, without murmurs, crackles, or edema. Why is he short of breath? Is it A, pneumonia, B, congestive heart failure, C, dialyzer reaction, or air embolism? And you guessed it, this is an example of air embolism. So an air embolism occurs when one or more gas bubbles enter into a vein or an artery. How can this happen? Well, for example, if you've got like a broken or loose Luer connection between the arterial needle and the tubing, that can result in air entry because this segment has a negative interluminal pressure, so it's sucking in air from the outside. If you have a hole in the arterial tubing, this can suck in air as well. Or, of course, we can do a bad job and introduce air during the administration of anticoagulation or saline. Air can block the passage of blood, so it can be life-threatening. And depending on where the blockage occurs, symptoms and severity vary, but often include shortness of breath, dizziness, anxiety, chest pain, and low blood pressure. The treatment essentially is supportive in making sure that all of our connections are tight and that we don't introduce air, say when we administer heparin or saline. Case number 11, a 24-year-old dialysis patient has had shortness of breath and chest pain since undergoing a declot of her dialysis graft yesterday. She's a febrile and normotensive without murmurs, crackles, or edema. There is no air alarm. Why is she short of breath? Is it A, pneumonia, B, congestive heart failure, C, air embolism, or D, pulmonary embolism? And the answer in this case is pulmonary embolism. Pulmonary embolism is a sudden blockage in the pulmonary arteries. These are the blood vessels that send blood to the lungs. Most clots originate in the legs, but in a dialysis patient with a clotted access, the clot is often dislodged during the procedure and can travel to the lungs, causing a pulmonary embolism. It's diagnosed with imaging tests such as a CT pulmonary angiogram or a ventilation perfusion scan. And patient, in this case, would be sent to the hospital and would be admitted for initiation of a blood thinner. Next case, 72-year-old chain smoking dialysis patient presents with shortness of breath. Patient is afebrile. He has normal blood pressure. On exam, he has a loud expiratory wheeze. Why is he short of breath? Is it A, pneumonia, B, congestive heart failure, C, air embolism, or D, COPD exacerbation? And survey says COPD exacerbation. So underlying lung disease is a very common problem in dialysis patients, particularly those who smoke. The most common underlying lung disease is COPD. Basically, COPD is a class of lung diseases, includes asthma, bronchitis, bronchiectasis, and emphysema. Common symptoms of COPD exacerbation include shortness of breath, coughing, and wheezing. Of course, these are non-specific symptoms which can be seen in other disorders such as congestive heart failure, volume overload, and pneumonia. The treatment of a COPD exacerbation in general includes supplemental oxygen, sometimes steroids, and antibiotics, as infection can sometimes precipitate a COPD exacerbation. Okay, case number 13. This is our last case. 24-year-old non-smoking dialysis patient presents with sudden onset shortness of breath. She's visibly anxious on exam. There is tachycardia, but no fever, murmur, or edema. Why is she short of breath? Is it A, pneumonia, B, COPD exacerbation, C, air embolism, or D, a panic attack? And survey says a panic attack. So panic attacks are sudden episodes of intense fear that triggers severe physical reactions when there's no real danger or apparent cause. They can be very frightening when the panic attacks occur. You might think you're losing control, having a heart attack, or even dying. Many people have just one or two panic attacks in their lifetime, but if the problem continues, if you have recurrent panic attacks, then we say that you have something called panic disorder. Common symptoms include shaking, nausea, dry mouth, sweating, dizziness, tachycardia, shortness of breath. Treatment can include cognitive therapy, anti-anxiety medication, and other supportive care. Okay, now let's shift gears and discuss briefly the management of shortness of breath. The first step in managing shortness of breath at the dialysis unit, regardless of cause, is the administration of supplemental oxygen. And of course, you all are excellent at this. The second step, as long as the patient is hemodynamically stable and not hypoxic, is to start dialysis and begin removing fluid. Remember that the number one cause of shortness of breath among dialysis patients is volume overload. And the treatment for this is fluid removal with dialysis. Now, if you have a dyspneic patient who presents at or close to his or her dry weight, then it's important to challenge the dry weight, particularly if that patient is hypertensive or if the patient has a history of heart failure. When should you refer a patient to the hospital? Well, if the shortness of breath fails to improve with ultrafiltration, so you dialyze the patient, you remove 3 kilos, and they're still short of breath, then I think that would be a reason to go to the hospital. If patient is hypoxic, they have room air oxygen saturation less than 90%, particularly after removing fluid with dialysis. If the patients are hypotensive, in which case you have to think about less common causes of shortness of breath, including cardiac tamponade, pulmonary embolism, infection, of course heart failure can do it as well. If someone has fever, they should go to the hospital because of the likelihood of pneumonia. And finally, if someone has new onset chest pain, they could be having a heart attack or an arrhythmia. Okay, let's summarize what we've learned. First of all, shortness of breath is a very common problem among dialysis patients. The number one cause by far is volume overload, but of course there are lots of other causes which we went through, including congestive heart failure, arrhythmias such as atrial fibrillation, valvular heart disease, anemia, pneumonia, metabolic acidosis, cardiac tamponade, dialyzer incompatibility, air or pulmonary embolism, underlying lung disease, and panic attacks. Management includes supplemental oxygen, fluid removal and challenging the dry weight. Refer them to the local hospital if their shortness of breath persists after dialysis, or if they're hypoxic or hypotensive or febrile or have chest pain. Okay, folks, it's time for the quiz. Question number 1, what is the most common cause of shortness of breath in dialysis patients? You got it, volume overload. By far the most common cause, when in doubt, if a dialysis patient has shortness of breath, that's number 1, 2, 3 on the differential. Question number 2, name 3 reasons to send a short of breath dialysis patient to the emergency department. You got it. Fever, thinking pneumonia, hemodynamic instability, so someone is hypotensive, which case you'd have to consider heart failure or infection or cardiac tamponade or pulmonary embolism. If they have chest pain because of the possibility of a heart attack, and if the shortness of breath fails to improve with ultrafiltration, or if they have room air oxygen saturation below 90%, particularly at the end of the dialysis session. Next question, what is the first step in managing a dialysis patient with shortness of breath? That's right, supplemental oxygen. Of course, you all know this, and you guys are great at this, um, but simple thing that we can do to alleviate dyspnea. Okay, last question. If you get this one wrong, you have to watch my whole video over from the very start. What should you do if a dialysis patient is short of breath but presents at his or her dry weight? That's right. Challenge it. Uh, the dry weight's probably wrong, so always try to remove fluid, particularly if the patient is hypertensive. This concludes the April 2023 in-service for the Northwest Kidney Center. Thank you so much for your attention. Thank you for the excellent care you provide our patients. This is Andy Brokenborough signing out. Until next month, take care.